Hello, I'm Dr. Jay Noreen, and welcome to Health Talk. Osteoporosis is a painful and debilitating disease found most often in the elderly. Our guest is Lynn Gilbert from OrthoCarolina. Welcome, Lynn.
Thank you.
You know, Lynn, you're a physician assistant.
Yes.
And would you tell us a bit about the education of a physician assistant and what you do? I taught PAs many years ago, so I know, but you know, there are people in the audience who don't exactly know what a PA is. If you could tell us a little bit about that, that'd be great.
Absolutely. Physician assistant is a provider that provides care to patients directly under the supervision of a physician. We're kind of an extenuation of the physician, so it kind of allows the physician to do his thing, but then also give us the opportunity to treat patients as well. PA programs are master's degrees typically. So you have to have a 4-year undergraduate, and then you go for your PA program, which is a 2-year or to 27-month program. I actually went to Jefferson College of Health Sciences in Roanoke, Virginia, but Appalachian now has a program. I think this is their first year. It's associated with Wake Forest PA program, so it's a great profession in my opinion.
Great, great, good. Well, thank you for being here.
Sure.
We're talking about osteoporosis. Osteoporosis is a complicated disease, I know, as an internist. You deal with it all the time. You're really an expert on osteoporosis. Tell us, what is osteoporosis exactly?
Sure. Osteoporosis is a disease where you have thinning of the bones. We commonly call it the silent disease because a lot of people have osteoporosis and never even know that they do. Unfortunately, the reason I kind of have an in on this is they end up breaking a wrist bone or a spine bone or a hip bone, and so we see them in our office at Orthopedics. Kind of our goal with treating osteoporosis these days is to find out people who have the disease before they have those fractures in hopes to prevent those fractures. At age 30-ish, patients actually start to lose bone density. People a lot of times think this is only for older patients or only for women, but at age 30, our bones start to slowly deteriorate. And depending on a lot of factors such as genetics and other medical conditions and medications that people do, lifestyle activities, people can lose bone very, very quickly. And so it's important, we think, to figure out these patients that are at risk and try to treat osteoporosis before it leads to these painful and debilitating fractures.
Age 30?
Age 30.
I think that'll be a surprise to a lot of people.
I think so
because,
too.
You know, I think most people other than medical professionals think of osteoporosis as something that happens really quite late in life.
Absolutely.
But it actually begins at sort of a
It starts at age 30.
natural debilitating process. It starts very young.
Sure does.
What causes it?
There are a lot of different causes. Like many other medical diseases, it is genetic. So of course, if someone's parents or grandparents had osteoporosis, they're more likely to have it. Just a normal aging process also causes it. So there's not an outside always factor. Medications such as thyroid medicine, steroid medications, those seem to weaken the bones. There are different other diseases that cause it. Absorption diseases where people can't absorb nutrients well, they will often develop osteoporosis. We find that different races, Caucasian races, Asian races, seem to have higher risk for osteoporosis. Smaller framed people, people who have not been very physically active. So there are a lot of different causes, and typically everybody meets at least one of those potential risk factors or causes.
How common is osteoporosis?
We're not 100% sure how common it is. Again, that's kind of why we call it the silent disease. We feel that there are around 10 million people in the United States who have osteoporosis, but again, there are lots and lots of patients who probably have it that we don't even know about. So it's a very common disease.
Now, does it affect both men and women the same, or is there a difference?
There is a difference, and a lot of people think it's only a disease that affects women, but it actually affects men and women both. It is more common in women, and a lot of that has to do with hormonal changes with menopause and hysterectomies and things like that, but it does happen in men. Steroid use and even some other diseases do cause it to happen in men, and men, as they get older again, their bones just start to weaken. So it does affect both men and women, just a little more often in women.
When do people notice the symptoms of osteoporosis? At what age typically would people begin to say, gee, something's bothering me, and might go and talk to their physician or their PA
Absolutely.
and say, this is bothering me? And when does that happen typically in terms of age?
That does normally happen later. I'd say minimum is about 60. And
Okay.
again, when we typically start to see the patient who comes in with those symptoms, it's more of fracture symptoms. So most of the time that's in the older patients. And it's not always a painful disease until they have a fracture, but certainly once they fracture, they end up with pain. So most of the time that's 60 or older for our patients where they start to see the wrist fractures or the spine fractures or the hip fractures.
Now, when you first see a patient, you get patients who have osteoporosis because that's your area of
Absolutely.
expertise. What's your first response when people come in and you're concerned they might have osteoporosis?
Right. There's a lot of history gathering at that point. You want to get risk factors, ask about all those things that I had mentioned earlier about smoking and medications and family history. You want to ask about fractures. Have they had previous fractures? Maybe they were 55 and had a fracture and didn't think much about it, but now maybe we should start to think about that. We ask about their history as far as physical activity because that's very important. Again, people who are sedentary have much thinner bones. People who are active seem to have better bone density. We ask about medications that they've taken, whether it's prescription medications or supplements, because of course the bones do well with calcium and vitamin D. So patients who have not been have a big calcium intake throughout their life may also have that issue. So it's a big history gathering time to start with. Once we get that history, if we feel that they either have or are at risk, then we start looking into lab tests and bone density testing to determine for sure if they have osteoporosis.
When should I, as a patient, come to the conclusion that I need to be checked for osteoporosis? How do I get to that point, not knowing the typical person what that even is?
Sure.
How do I know that I need to go and have this checked out, whatever it is?
Across the board, we say that women at age 50 should have their first screening bone density exam. Unfortunately, sometimes insurance companies kind of fight us on that a little bit, but that's our standard recommendation. If patients have more risk factors, sometimes we do it sooner. If they don't have as many risk factors, we may push it out and do it later. For men, we typically say age 65, we need to start with that first screening bone density. Based on the results that we get on those original bone densities, we kind of decide how often should they have that rechecked.
Okay. Now, when you say screening bone density, what does that mean to the patient?
Sure.
And when I'm 50 and I'm a woman, I need to go have screening bone density,
Exactly.
but I don't know what that is. So
Sure.
what is that?
It's a very, very simple test. People are always saying, are there needles involved? But no needles involved. They actually go into the imaging center. They'll lay on a flat table, and there's an arm that kind of circles over top of them. And we typically check pictures of their hip and their spine because those are two common spots to fracture. It takes about 15 to 20 minutes, and then that bone density report will give us a number. And we use that number, which is called a T-score, to figure out how their bones compare to other people of their age. And that way we kind of know which sort of category to put them in. There's a category of normal bone density. There's a category of osteopenia, meaning starting to get a little bit thin. And then there's that category of osteoporosis where certainly some sort of treatment should at least be discussed.
So the category has to get to that last one, osteoporosis, in order for there to be treatment. If it's osteopenia, then what do they do?
Not necessarily. We look at the patient as a whole. The bone density test is a great exam. It gives us a lot of good information, but it's not perfect. So if I have a patient, say we've got a woman who's 65 and she has a bone density, she falls in that osteopenia range, but she's had a wrist fracture, she's had a shoulder fracture, she's had a foot fracture. She never really has had much calcium because she's lactose intolerant. She had a grandmother who had a hip fracture. All those things are other risk factors, so it makes me concerned that she probably does need treatment sooner than a patient who doesn't have all those risk factors. So we do have to look at the patient as a whole, and we don't use just those numbers that we receive, but it is a part of it.
Okay, but from the point of view of, as an individual, number one thing for me to remember, if I'm a woman, is age 50, I should get a diagnostic test.
Get a screening test.
The screening test.
Yes.
Just routinely,
Yes.
whoever I am. But if I've broken a bone unexpectedly, even if I'm younger than that, then I should probably also get the test earlier. Is that right?
Not necessarily.
Okay.
We kind of look at the way you broke the bone, the type of fracture, the location of the fracture. If it was a car wreck and the car flipped 3 times, probably you're expecting to have a fracture. Certain bones are more likely to be seen broken in osteoporosis, so we look at the location of the fracture. So it varies. It's not just cut and dry about, hey, I've had a fracture, so I need a bone density. But again, we look at that patient as a whole. If that patient had a hysterectomy at age 25 and had some of those other risk factors and then had this fracture of one of those sites that is common in osteoporosis, we may check that sooner.
So why is it important to consider more seriously getting diagnosed or getting screened if a woman has had a hysterectomy? Why is that important?
When you have the hysterectomy, they lose those hormones that we circulate around when we've got a uterus that's active. Those hormones do are protective for the bones. So once those hormones go away, the bones certainly start to lose strength more quickly than the patient who has those hormones still circulating.
So it's an entirely a hormonal
It
effect.
is.
Okay. So that's step number one. When
Yes.
do I need to get checked out? And if I'm a man at age
A little bit
65,
later.
make sure I get a screening test, and that'll tell me what I worry about next, or
Right.
nothing if I'm lucky.
Right, right.
So, so let's say we've done that test, and it does indicate that I should be worried. What do I do next?
That's when I certainly start my patients on calcium and vitamin D supplementation.
Okay.
We make certain that they're getting good levels of that in their diet or through an actual pill supplement. I do often do blood work on those patients. Sometimes there's another cause for the osteoporosis or the osteopenia, and so we want to rule out any other cause for that. If you can take care of the cause, it may help take care of the thickness of the bones. And then we typically get them as active as possible too. There's a couple of reasons. Putting stress on those bones makes them stronger, plus keeping the muscles strong keeps the balance better, so we keep patients from falling hopefully, which could cause fracture in people who have thinner bones. After all of that, we follow them along. Typically every 2 years we recommend repeating the bone density to make sure that they're not worsening. And if
Okay.
we see that they're now worsening or they've dropped down into that osteoporosis range, then we may discuss treatments such as prescription medications for osteoporosis.
Okay, okay. So there are a couple of things if I'm at that stage, once I have been screened. One of them is diet,
Yes,
and in particular, you mentioned calcium.
Calcium.
And vitamin D.
yes,
And then secondly, exercise is important.
Yes.
And that's because it helps build the bone.
correct.
And then good muscle balance and strength is important. And the reason for that is because if you got good muscle strength and coordination, you're less likely to fall down. And if you
Exactly.
have weak bones, osteoporosis, when you fall down, you're more likely to break
Right.
something. Okay, does that capture
That's
it?
exactly right.
Let's go back to diet and calcium and vitamin D. What's important to remember as an individual? What kind of diet things are really important for me for vitamin D and for calcium?
Sure. Calcium are your standard things such as milk and cheese and ice cream and yogurts. Vitamin,
sounds pretty good.
That's not too bad, is it? Patients like to hear they can eat their ice cream.
Right.
Vitamin D, a lot of foods are fortified with vitamin D. You'll see cereals are fortified, orange juice is fortified, so that's a way that you can get some vitamin D. A lot of patients, though, just have a really hard time getting enough of it from food alone, and so that's why we do often recommend the supplements. My recommendation for daily calcium is 1,000 to 1,200 milligrams. I do like that split up into 2 different doses and taken with a meal. It seems to help the absorption quite a bit. And fortunately, most of the calcium supplements we have now have the vitamin D mixed in, so that way the patient doesn't have to take 2 separate pills to get that. And it is important. If there's not enough vitamin D circulating, then the calcium really isn't doing a whole lot of good. So it's important that patients have both of those.
Uh-huh. Now, how do I get that? Is that a prescription, or did I just buy it over the counter?
It is over the counter. We do often find that patients are vitamin D deficient. That's one of those lab tests that we often check with patients we're concerned about for thin bones. And there's a prescription dose of that we will sometimes give for a period of time to try to get their vitamin D level up to a normal range. And then they can hopefully maintain with just the over-the-counter medication.
So now, if it's over the counter, how do I know how much to take? Do I just read the bottle, and should I take that even when I haven't been diagnosed with osteoporosis or not?
In my opinion, when you hit that 30-year mark, you ought to start thinking about getting your calcium and vitamin D. And again, if you say, hey, I drink lots of milk, I eat lots of cheese and yogurts and dairy products and dark green vegetables are also other things that have calcium, then you may be okay. But I actually encourage my patients to look at the milk, look at the cheese, and see how many milligrams of calcium they're getting, and try to add that up on average. And if they're getting 600, then maybe they only need to take 1 supplement instead of 2.
Okay.
Typically, the supplements do come in 500 to 600 milligram pills, and so they can do the 1 with breakfast and 1 with dinner, and they know they're getting their needed amount.
But they don't need to keep track of the milligrams. They just need to read the bottle, basically, right?
Right.
So this is fairly straightforward from the point of view of going to the drugstore and buying
Yes.
something over the counter.
Yes.
Unless it gets severe, and then you may go to a prescription.
Correct.
Now, what are the prescription things that you would use in the more severe cases?
For the prescription osteoporosis, there's a lot of different medications. Years ago, we had a group of medicines called the bisphosphonates, and I think just about everybody's heard of Fosamax and Actonel and Boniva. They were all over the news for quite a while. Originally, we really thought they did a good job. They were certainly what we had, and they seemed to work pretty well. They've been out for many years now, and we're starting to learn that maybe they're not quite as effective as we hoped they were. And they're also causing some side effects that patients hear about, and they're very afraid to take the medication. So it's not as commonly used, but that is a potential option. These are pill medications that they do get from their prescribing physician. They take them either weekly or monthly. I've found a lot of patients have a difficult time taking them just because there's a lot of restrictions. You have to sit upright for 30 minutes or an hour. You have to take it first thing in the morning on a completely empty stomach. You have to have a full glass of water. So some patients really fight me that they can't have their coffee or they can't have their breakfast. They have to wait that 30 minutes or an hour. It also seems to cause a lot of side effects as far as the esophagus and the stomach. A lot of people just cannot tolerate it from a side effect profile as far as the symptoms they get from heartburn and ulcers and things like that.
So it's a real prescription drug.
It
It's
is.
the kind of thing you don't want to take unless you really need it.
Right.
And if you need it, you need some advice on how to
Absolutely.
on how to do it.
Absolutely.
But again, that's when it gets pretty severe.
That's when
right?
it gets
That-
severe.
Not typical.
Right. We actually also have a couple of newer medications that I actually use more often now, and they're both injectable medications. So that's something else that I will discuss with patients. They're a little bit newer, they're a little bit stronger, and they seem to have fewer side effects. One is called Prolia and one is called Forteo. One is an every 6 months injection they receive at the doctor's office, and one is a daily injection they actually give themselves.
Oh, I see.
So
Okay.
it can be a little difficult educating patients on those because nobody wants a shot, but they do seem to work very, very well. So we have some pretty good options these days for treating it when it gets to the point where we feel it needs to be treated with a prescription.
But you hope that you'll be able to prevent it from
We
getting
want to
that
prevent
point.
it. That's our goal.
Now, you mentioned exercise, too. How does exercise help, number one, and what kind of exercise?
It has to be weight-bearing exercise. Whenever we put stress on our bones, our body kind of knows it has to be stronger. And in order to be able to do those sorts of things, it has to be stronger. So it seems to keep the bones stronger. Swimming's not as great, sitting on a bicycle is not as great, but walking, dancing, weightlifting, all those sorts of things where you actually put stress on the bones cause the bones to become stronger or remain stronger.
Okay. And how much exercise is appropriate and reasonable?
Sure. My goal for patients is 20 minutes per day. That's
Okay.
that's what I ask them to do, 20 minutes a day of something they like to do. And that seems to work out pretty good as far as being manageable, but also doing a good job for their bones.
Now, 20 minutes a day of what kind of exercise? Just to get a little more detail into what would be a good thing for me to do if I wanted an exercise program and I was going to do it 20 minutes a day, and what kind of variety would be reasonable?
The simplest thing is the walking. Walking does a great job as far as putting stress on those bones, especially the lower extremity bones. So that's the number one thing that I recommend to patients. Sometimes patients don't really enjoy that, or they've got bad knees or something like that, and they can't do the walking. That's when I think about other things. They can do the machines, or they can do hand weights, and that at least gets the upper body going a lot. I have a lot of patients these days who like dancing. That seems to be a big new craze as far as exercise goes, and that's great because, again, it works with the balance, and it also is weight-bearing for those bones.
Now, what can you do if you do have problems with knees and walking is not so easy? Are there other alternatives that work?
There are. The elliptical machine is a decent option. It's not quite as good because there's not as much stress on the bones, but at least you're still kind of upright, so you're putting some stress on the bones. A lot of my patients with bad knees can do like the weight machines as far as sitting down doing leg curls and things like that. So it puts some stress on the bones. It's not as good. We do still have the pool workouts, water aerobics, things like that, which is kind of better than nothing, I guess would be the way to put it.
Yeah, yeah. You mentioned there's some other things that make people inclined to get osteoporosis, just besides age. What are those things? What kind of things should people think I better worry about osteoporosis because I have this issue?
Sure. The number one thing other than age would be family history. Anybody who has had a grandparent or a parent with a hip fracture, we're very concerned about. Then the race, Caucasian race, Asian race, those are two important ones. Body frame. Certainly our smaller patients have a much higher risk of fracturing than our larger patients do. Low calcium intake, if you didn't like milk as a kid or lactose intolerant throughout the lifespan, we worry more about those patients. Medications, thyroid medications, rheumatoid arthritis medications, prednisone medications, they'll do a number on your bones. The hysterectomy issue for people who have, at a younger age, the hysterectomy, that's certainly a big risk factor. Smoking can be a risk factor. Excessive alcohol use can be a risk factor. So there's a lot of things that go into bone health.
So smoking and alcohol use are risk
They
factors.
are.
you know, there are various degrees of both smoking and
Absolutely.
alcohol use. What are the kind of levels that you should be concerned you don't get to that level?
Sure. In my opinion, with the smoking, any of it really does
Okay.
affect it because
Okay.
it just affects your body on a big level, even small amounts. Alcohol, it really does have to be excessive. You know, for patients who drink a glass or two a day, I don't think it's an issue.
Okay.
It's more excessive amounts, certainly, that cause damage.
So some of those things we've heard about, for example, heart disease, 1 glass of red wine is actually a good thing. So
That's okay.
that wouldn't be too much for osteoporosis.
It wouldn't. It wouldn't. That would be okay.
Okay, that's important to know. Good. Now, what can I do to prevent getting osteoporosis? Are there things I can do? I know you mentioned diet, and that makes a lot of sense. What else can I do to decrease the chance that I'm going to get osteoporosis?
Sure. What you have to do is you have to think about those risk factors. And some of those risk factors we can kind of prevent. Some of them we can't. You know, we can't change our genetics. We can't change our race. We can't change things like that. We can try to stay away from medications that cause thinning bones. Sometimes we can't. You know, if we have rheumatoid arthritis, we may have to take those medicines. But we try to avoid those sorts of things. We try to stop the habits, the smoking, the things like that seem to make it worse. And then other than that, it really is just doing those 2 preventative things of these weight-bearing exercises and the calcium and vitamin D supplementation.
So those are the 2 main
Those are the
things.
2 keys.
Weight-bearing exercise, walking if you can,
Yes,
20 minutes a day,
20 minutes a day.
and other things like that. And if you can't, then you mentioned the various machine kind of
Correct.
exercise, or even some swimming. Oh,
Sure.
that's not as good. But otherwise, watch your diet, and over-the-counter supplements will do the trick most of the time.
Most of the time.
Unless it's quite severe. Good, good. Okay, well, this is obviously something that a lot of us have friends and maybe
Absolutely.
ourselves have experienced. So it's a common thing in our society, basically.
It is.
The thing that I think is quite impressive that you talked about is the timing difference for men and women. It's much earlier for women than it is for men.
Correct.
And now, say again, why is there that difference?
The big difference is the hormonal change because, again, the hormones are what keep the bones most of the time pretty strong for women. So once we hit that menopausal age or once we have that hysterectomy, it really makes a big difference. It's a big change inside the system, and that seems to be a real trigger towards those bones beginning to become thinner faster. Men don't go through that quite as much, and so, you know, their hormone levels are different, of course, and they affect the bones a little bit differently. So that seems to be the biggest difference between men and women. Also, it seems that men normally have a little bit more sturdy of a frame to start with. So it's kind of, if
Okay.
you start with a little bit more bone density, it takes it a little bit longer before you start to lose a lot of that. So
Is that related to exercise as well, the differences
Somewhat.
in exercise patterns? Or?
absolutely. You know, you do think a lot of times men have more strenuous activities as far as their workplace activities and things like that. So a lot of times they are more physically active than women are. And of course, that stress on those bones does keep them stronger longer.
Yeah, yeah. Now, so I'm a patient, and I've been concerned, or my primary care physician has caused me to be concerned about the possibility of osteoporosis. How do I go about coming to see you? And you take care of people with osteoporosis a lot. So
Absolutely. It is a little bit difficult. We've found with osteoporosis that a lot of patients don't think about it, a lot of providers don't think about it. They're busy, they're worried with the diabetes, and they're worried with the hypertension, and they're worried with all those other problems that are kind of shouting, hey, you have to do something about. So a lot of people and even providers don't think about that disease. As far as our clinic, we do not require referrals. We are trying to spread the word as much as we can to the providers around the area that we're here, that we're offering these services. We're trying to get out into the community and let them know as well, just to let them know that we're here to take care of that for people who want to do so.
Good, good. Well, Lynn, thank you very much. This is really
You're
interesting,
welcome.
and there are an awful lot of people, I think, who are going to benefit from
Good.
the insights you've given.
I hope so.
We all know family members and others who have suffered from this. You mentioned a couple of times that fractures are sometimes the first thing that you see. What kind of fractures happen?
You really can have a fracture at any site, but the 3 most common that we see are hip fractures, spine fractures, and wrist fractures. Those seem to be the spots that give people most of the trouble. But we also see shoulder fractures, we see foot fractures, we see tibial plateau or fractures just below the knee. We see finger fractures, we see hand fractures. So there's a lot of different kinds, but the 3 biggies for patients with osteoporosis are the hip, wrist, and spine.
And are they treated differently with people with osteoporosis than if they're for some other cause, or is it pretty much the same?
It's pretty much the same treatment. You know, our goal is to get the fracture into a good position and let it heal. Sometimes the treatment lasts longer or takes longer because the bone heals a little more slowly than if you have a young, healthy patient who has good bone. Sometimes, too, it makes it a little more difficult because some of these have to be treated surgically. And if the bone is not very good, sometimes it's hard to do surgical treatments to hold the bone into a good position. So it's the same thought process as far as fixing it, but sometimes it does make it a little more difficult for it to heal correctly because of the thin bone.
Good, good. Well, again, Lynn, thank you very much. This is great information that will, I think, be valuable to an awful lot of people.
Thank you very much.
That's our program for this week. Please join us next time here on App TV. I'm Dr. Jay Noreen.